Hi, this is Karim Khan, and I'm delighted to have this opportunity to present via Zoom on a recording. And I'm sorry that I can't be there in person, but I know it'll be a fantastic success. And I know my great colleague, Dr. Peter Bruckner, is with you in person, which I'm delighted to know. And I wish you every success at what I'm sure is going to be a fantastic meeting. I'm going to share screen and go through some slides with you. So I think that should see us in the, just make sure we go to presenter mode here. So um, congratulations on the conference, as I mentioned. And then this presentation is about explaining how exercise works to athletes. So the time I'm going to spend with you is this idea of when you're speaking to athletes, you know that exercise works well, but we need to convince, educate, make patients understand. Otherwise, they may think, well, what about an injection? Or what about some other kind of medication? Or why should I do the work? And so this comes under the broad umbrella of shared decision making, of course. And we don't have time for me to go through shared decision making in detail, but there's fantastic work on it by Glenn Elwyn from Wales in the United Kingdom and other folks. And we often do shared decision making without knowing that we're doing it, in the sense that we listen to the patient, we discuss the options, and then we make a plan together. So the deal here in this presentation is when you're faced with a patient who's doing, whom you're going to prescribe exercise, we want to engage them and make them understand why exercise is going to make sense. So let's begin with the facts. And the first fact is that exercise is clinically effective. And I'm not going to spend time or waste your time convincing you of that. You know that. And if we only had a little bit of time to provide some links, there's a nice systematic review that shows that exercise works for tendon problems in this case. And the basic elements of it are isometric exercise, energy storage loading, and then energy storage release. So progressive exercise will help a tendon repair. And we're going to go, but how does it do that when we, in this particular 20 minutes that I'm going to spend with you? So in this scenario, you can imagine we as health professionals know that exercise is good, but you can imagine an athlete that's been doing more training and they've been told by everyone this is an overuse injury and you've done too much. And so in their mind, if we stick with the tendons for now, it's this idea that they've injured their tendon, like I've done too much load. And so there can be a knee-jerk reaction to say, well, what about resting so that I avoid the harmful stimulus? So if I was doing this with you in person, we would have a participation activity where I'd ask you to talk to a colleague and explain to them how you actually explain to the patient why exercise is good for them. So let's stick with Achilles tendinopathy for now, and then take it in turns in this activity where you would say, okay, let's say it's I'm pretending to be the patient, and then the pair of you in the room would do this conversation where someone would say, well, Karim, explain how you would convince the patient about exercise being good for you. And the reason I'm doing this is for you to be thinking and engaging and doing some hard work, because it'll help you appreciate the rest of the presentation rather than passively sitting back and waiting for me to share the answer. So depending on the organisers, if they wanted to stop the video, they could, and have you spend 2 minutes engaging and talking about this activity of how a tendon works, or we could roll straight on in the interest of time. So here we've moved on, and I've said, look, I think it's about strengthening, or I think it's about extra blood flow, or I think I've speculated as to various mechanisms as to how it can work. So now moving to me as a speaker, as a guest speaker, I'd summarise and say, look, patella tendinopathy, Achilles tendinopathy, exercise can reduce pain. And so here's Lorimer Mosley's photo, who's an expert on pain, and pain science is clearly part of how humans recover from injuries. So that's the first option, but we're not going to go into that in detail. Exercise can improve tendon function. You get better motor control. You load the local region. You might load the shock absorbers. So for patellar tendon problems, you might take more shock absorption with the calves and better dorsiflexion of the ankle. So a bit more springy. So you're going to limit the load at the patellar tendon. But the thing we're going to focus on today in the next 20 minutes is this improving of tendon structure, because the power of exercise, it actually does help with structural repair of tissue as well as its functional benefits. So that was fact one, was the systematic review saying exercise works clinically. And fact two is that there's evidence for loading, stimulating repair of tissue. And so in this example here of the bone, patellar tendon bone, ACL reconstruction situation, that you know well that the surgeon takes the middle third of the patellar tendon away. So there's definitely a gap, and that's not sutured even. That's left to fill in. And so what happens there is, if we looked under with repeated MRIs, we would see here's a cross-section of the knee. And so we've got the femur in the middle, we've got the patella on the top, so the person's lying down face up. So there's supine. And so here you've got the patella and then the skin over the top. And so the tendons are black in cross-section. It's in this shape in cross-section with the yellow arrow. That's the patella tendon, and it's attached to the patella. And so then what happened is that they MRI'd patients recovering from having their middle third of the patella tendon cut out, and they reviewed researchers reviewed the patients at 8 weeks, at 7 months, and at 2 years after the surgery. And then here's the same orientation that we looked at before. So the black is the patella tendon, and here's the gap with MRI of the patella tendon between these X's. And so there was a 7 millimeter gap at 8 weeks. This gap had shrunk to 2 millimeters by 7 months. So that's structural repair. And at 24 months, the gap was absent. So the tendon had filled in over that 2-year period. Now, was that tendon perfect? Was it like a 20-year-old's tendon? No, of course it wasn't. It was a repair. It's different type. It's not as much collagen type 1. It's more collagen type 3. But the important point is that we've got proof of tissue being able to repair with loading where it had been cut out. So the question then is how, and that was the discussion I was hoping you would have had in our either theoretical or real discussion about 4 or 5 minutes ago, right? Like, how does loading improve structure? And this is the important message for patients, because if they understand that exercise is proven to work, they're more likely to stick with the program and give you a chance to help them recover fully. So there's a few options if you think about it from a mechanistic point of view. And so there can be collagen synthesis. And so when you create new collagen, then that gets laid down and the tendon gets remodeled. What creates the collagen? Well, a tendon cell has to create collagen. So the tenocyte, which is a specialized fibroblast, that might be made more active by exercise. Blood flow can be helpful, but I'd argue that it needs more than just blood flow. And then remember, when in the repair phase of any injury, you get new blood vessels growing in, but they are part of the abnormality in tendinopathy. Remember, under the microscope in a patient with tendinopathy, there's more blood vessels than there are normally. And then a tendon can become thicker and swollen as part of the repair process, because thickness gives you more material to be strong, right? If you're trying to build a building, if you have thicker struts, then that makes the building stronger. And so in a tendon, a thicker tendon, if it's equal quality, will be able to hold more load. So these are all ways that tendon can repair. And I'll take you through these steps in an illustration. And so this is the key new part, and this is a new set of pictures in India. These haven't been shown in India before. And they're variations on our 2008 work, but they're new in 2024. So I created these earlier in 2024, and they're in the chapter in Clinical Sports Medicine, Foundations of Clinical Practice, that explains the basics of treatment, because this is under the exercise treatment chapter. So we've got A, B, C, D, E, and F. So we've got 6 pictures, and each one illustrates a certain step, which we'll go through in detail. But in terms of a preview, you can see the person doing the exercises with this cursor. If you can see this cursor, you've got the person doing a heel drop. So we're focusing now on a heel drop for Achilles tendinopathy, but it applies to other tendons and applies to other tissues. But for the purpose of illustration, let's stick with this Achilles tendon, and you can see the little box on the person on the left. We are going to go through these in more detail, but by preview, you'll see abnormal collagen. So this brown grey color is the abnormal collagen. And then it contrasts with, at the end here, they've got the repaired collagen. So normal collagen is golden. So that's the difference here. You've got abnormal collagen in what I'm going to call a brown color. And then golden, healthy collagen is at the back end. Now, this collagen is removed, and what you're looking at in the green are tendon cells. So you're seeing a network of tendon cells that build the collagen, but the collagen has been removed largely from this image. And I'll go through it in detail, but this is giving you, if we call these characters in a play, right? If this is a Bollywood movie, there'd be a character, would be the collagen would be one character, the tenocytes would be another character, and that had a certain job. And then the tenocytes has a nucleus inside. And so here we have the load activated nucleus, which we'll look at in more detail. Then we're going to hone in with the microscope and look inside that nucleus. And then you'll see that the nucleus is a sort of a preview here, like a teaser, as they call it in North America, or a trailer. That collagen, that nucleus is going to release collagen, and that's going to be the hero and fix the tendon, literally, in terms of a preview, okay? So your job there was just to understand that there are a bunch of characters, and they're depicted in certain ways with this cartoon, and I'm going to walk you through those in a step-by-step basis. So we'll go through this in detail from that preview. So the concept of mechanotherapy is where there's some exercise loading, and this is where this picture takes place. It's in the Achilles tendon itself. I've put it in the mid portion where often the tenderness is and the pathology arises. So it's different to insertional patellar tendon, Achilles tendinopathy, but let's focus on the most common spot. And I made the point that this brown color is abnormal collagen. So the exam question is, what's this green? That's not collagen. The green are the tendon cells, which we're going to get to. And this cigar-shaped element is the nucleus. So that's the sneak preview. But here we're looking at abnormal collagen, the person's doing exercise. And then we progress that forward. We remove that collagen to make it easier to see the tendon cells, the green. So we removed those characters, the collagen. There's collagen in the background here that we haven't removed yet, but we're focusing on the tenocytes. We're bringing them to the forefront. We're shining the light on the collagen, on the tenocytes, because that's tenocyte equals tenocyte, tendon cell, and that's a specialized fibroblast, and that's a factory that can make new collagen. So that's why we're focusing on this. And this has a nucleus, and that's the brains of the factory. That's where the action gets created. And this is the tendon cell, looking at it from the outside into the nucleus. And it has a bunch of elements that make it sensitive to load. I won't go through each of these in detail. We'll just stay at the top level. But there's the nucleus, which we've alluded we're going to get into in more detail. There are adhesions, which we're going to look at in more detail. It's called integrins. And that's a connection between the cell itself and the matrix. So this arrow goes to here because the matrix is the collagen, and you have to have a communication between the collagen and the cell itself. So that's what's called cell matrix adhesion. There's a sticky switch, and the integrin is what we're going to talk about in integrin. So these are elements of the cell. that allow the cell to respond to load. So the focus of this slide is, well, how does the cell sense load? The cell has the capacity to communicate load. So this cell has a door, a trapdoor, and it can communicate a loading message to the adjacent cell. And there's a cytoskeleton. I'll show you a picture of that, but there's a small skeleton inside the cell that transmits messages as well. So the point of this slide is that the cell, this green box, which has the membrane around it, the cell membrane, and these integrins, is able to sense load. So it's not a surprise that exercise works. It's like this thing is designed to sense load. And when it senses the load, it gets into start working to make more collagen. Let's look at that in a bit more detail. That was a simplified cell, as you saw, that had the cell membrane. We didn't show these integrins in detail, but here they are. They're a switch from the outside of the cell where the collagen is to the inside of the cell, and the arrows show the direction of the message to the nucleus. And there's also a little skeleton inside here that allows this message of exercise to get into the nucleus. So that's all we need to say here. The nucleus, it's got this yellow circle around it to show that it's activated. And then what the nucleus does, so we've shaved away half the nucleus. So looking inside the nucleus, there's a thing called a nucleolus, which is where the DNA is read. And then that's getting a message out to make pro-collagen, so little bits of collagen that get put together by the endoplasmic reticulum, this rough endoplasmic reticulum. So remember, some of you from microbiology and biochemistry and anatomy, that their cell nucleus has an endoplasmic reticulum. It's like a factory adjacent to the nucleus. And here it builds the pro-collagen and then extrudes it into the cell, into the matrix, out of the cell into the adjacent area where the collagen has to build up. Okay, so one last summary. DNA makes pro-collagen, tiny bits of collagen, because it can't get out of the cell if it's too big. These pro-collagens get constructed together, and they're extruded from the tendon cell, this green tendon cell, out to the tissue. And so then they can pop in here. You see how they're coming in here to repair this collagen. So if you look at this dark brown, that needs to be repaired. And so that cell made the collagen, which goes in and it'll fill in and make this a golden yellow from its dark brown, thick collagen status. Okay. And then the last point as we bring this to a close is that I said that the tendon cells communicate. Remember when you looked at that individual tendon cell that had the trapdoor to the adjacent tendon cell? So that's the example right here, where this one tendon cell near where it says IP3 has got a trapdoor out to the adjacent tendon cell. So think of, if everyone in the room reached out to someone else and held each other's arm, you'd make this amazing network throughout the room. And so the messages can get through from one person to another. You could shake and shake and shake, and you can shake from one corner of the room to the other corner of the room, people holding hands. Well, that's what this tendon cell network does. Remember, these green is the tendon cells. The golden collagen's in the background. We've washed that away in the front here so we can focus on the cells. And so a message can come from one area, like let's say up the top right hand here, and it can come through these doors and spread down through this cell, across through this trapdoor into this cell, and then through this trapdoor into this cell, and you get the pattern through this trapdoor into this cell. And so the message of exercise can be spread through the tendon, and all these little nuclei get switched on going, look, we've got to make more tendon, we've got to repair this tendon, we've got to make collagen, which you saw in the previous slides, okay? So then to summarize, we began by saying excessive load might injure tendon, and we made the point that rest, doesn't provide any stimulus repair. And if you've just got the person sitting there not doing any exercise, they won't repair. We know that from clinical trials. We began by saying that the systematic reviews show that exercise repairs tendon, and it does that by having the optimum load, which is stimulating the mechanotransduction that I shared with you, and simulating healing. I'll let that sit for a second. That we've gone for a two-part model: underload or rest, excessive load injury, optimum load mechanotransduction. And then if you just want to take a different view of this, if you want to see this again, you go, look, Karim, I didn't quite, understand that. But I've got a feel for some of the players, the tendon cells, the collagen. I need to maybe reread that. Another way to look at it is say, look, you've got normal tendon here. So in this case, the tendon's red because it's a different form of staining. So this is, I mentioned it's a different approach. It's just a short summary, but it's taking a different angle if you didn't quite capture what I was talking about. So the collagen is in red in this case. The nucleus is in this dark stain of the dark blue, black color. And so you see that they're interspersed and there's more of them, but they're hidden by the collagen, which is why I removed the collagen in the cartoon. But if we, have too much load or too little load, then what happens is these nuclei get switched on, and that's why they're rounded, because they're being active, they've switched on. That's the best way to say it. And what's happened is you've lost the normal collagen bundles. You've got just this mess because the collagen is failing. And you've actually lost some cells in certain areas because they failed too much and they died. But then with the appropriate load, these nuclei are switched on, they're making that collagen I illustrated for you, and then that promotes tissue repair and you start to get back to more normal tissue. So this is another simple way of showing that cartoon just in one slide. And there are a bunch of growth factors which have been studied that both lead to pathology. So the damaging collagenases, for example, enzymes that break down collagen. And then there are growth factors like insulin-like growth factor that drive things this way. So it's a nice illustration if you want to take a photo of that. I think in one slide of excessive load causing pathology, appropriate load causing repair, and very nice basic science underpinning these processes that's well characterized. And they're, the growth processes promote cell proliferation. So they make more of those cells that have the factory inside them. They make protein and they make collagen. Okay, so to summarize, in 3 pictures then, another 3 pictures, you've got the loading. I want you to remember the cell nucleus as being the driver, the specialized tenocyte, which can make new collagen. The new collagen is extruded from the cell and repairs the collagen, which is why we can be really confident when we're prescribing exercise to patients that it is very effective treatment for tendon problems in different parts of the body, Achilles, patella, elbow, shoulder. And then this does apply, this principle of mechanotherapy with the cells being stimulated applies to other tissues. So for bone repair, you have bone cells being stimulated. For articular cartilage repair, you have articular cartilage cells being repaired, being stimulated. And thank you very much for the opportunity to make that presentation with you. I wish you every success and appreciate the opportunity to have been had this time with you. Thank you very much.